Good evening, everyone, and welcome to our Trauma-Informed Healthcare for People with an Intellectual Disability webinar. My name is Nicole Radford, and I'll be the facilitator this evening. Alongside me is Kerry Robinson, also Project Manager of the SPIDER Project, supporting people with an intellectual disability to access health, and Jade, Workforce Development Officer at the Western Victoria Primary Health Network. I'd like to begin by acknowledging the traditional owners and custodians of the lands and waterways from which we are all zooming in from today. We recognise their diversity, resilience, and the ongoing place that First Peoples hold in our communities. We pay our respects to the elders, both past and present, and I wish to extend that respect to any First Nations people connecting in today. We commit to working together in the spirit of mutual understanding, respect, and reconciliation. We support self-determination for First Nations peoples and organisations, and will work together on closing the gap. Just a little bit of housekeeping. The majority of our webinar events are recorded and freely available on our PHN Learn YouTube channel. Jade will put a link to access our recorded webinar events into the chat. I have our upcoming events on the screen. You can register for our events on the website, and Jade will put the link into the chat for you. A special mention for our upcoming Primary Care Conference. This is a hybrid conference where you can attend from Geelong, Horsham, Warrnambool or Ballarat venues, or dial in remotely. The theme for 2023 is Toddler to Teen Health, and we look forward to seeing you there. Please make note of the Western Victoria Primary Health Network Health Pathways page relating to topics that are shown on the screen at the moment. If you have entered this webinar not displaying your accurate first and last name, please type your full name into the chat box. Only admin will be able to see this, and this will ensure that we can issue you with a certificate of attendance for today's event. For this evening's webinar, all participants will remain on mute, and if you have any questions, please type them into the Q&A box, and I will ask them on your behalf to the presenters during the Q&A time at the end of the presentation. There is a link in the chat box to complete the survey after the webinar, and we will show this slide again at the end of the presentation. So this evening, we will hear presentations from Dan Moss, Workforce Development Manager at Emerging Minds, and Kate Headley, Certified Practicing Speech Pathologist from Kate Headley Speech Pathology. I'll now hand over to Dan and Kate to deliver their presentation. Thank you.
Thank you so much, Nicole. Really appreciate that. And yeah, wonderful to be joining with you all tonight. I'm just going to share my screen. So bear with me for one moment while I do that. Right. There we go. So welcome everybody to tonight's webinar, which is supporting children with intellectual disability who have experienced trauma. Really want to thank Kate Headley for joining us tonight. Kate's a very experienced speech pathologist who has got lots of experience working with children around trauma with intellectual disability. So welcome, Kate, and hello.
Thank you. Hi, everybody.
We'd just also like to obviously echo Nicole's sentiment and acknowledge the different lands in which we all meet on tonight and pay our respects from Emerging Minds. And so tonight, I want to start by thinking about the experience of children with trauma who have intellectual disability. And Emerging Minds, over much of the last 5 or 6 years, a lot of our work around supporting children's mental health has been in the trauma area and has also been in the disability area. And I suppose what we've found in terms of children's mental health is that the effects of their mental health where they've gone through trauma and not being able to tell their story has been quite pronounced for them. And so part of our job really at Emerging Minds has been to encourage practitioners, both specialist trauma practitioners, but also generalist family practitioners, to be able to identify and support children to tell their stories. So we're going to go through a bit of Emerging Minds content tonight around trauma and specifically around children's intellectual disability, but we're also going to hear a lot from Kate about Kate's practical experience in working with children. Just kind of, we've tried to make sure that not too much of tonight's content is particularly triggering, but please, feel free to take a break if that's the case. I'm going to start tonight by introducing a character that we use quite a lot in our trauma content at Emerging Minds, and that's secrecy. And really, why we do this is really trying to think about the many different ways that secrecy plays a role in children's lives. Where they've been through trauma, particularly where they might have communication details. I suppose all of the ways that children are prevented in institutions or other adult-centric settings from telling their story and what that can mean for them. That's been obviously a really corrosive effect on children's mental health over the years, and something in Emerging Minds that we're really cognizant of. So I'm going to play you this snippet now.
I find myself in an unfamiliar position. I mean, I don't usually talk to anyone else, except for the child, of course. That's the child who's been through unspeakably scary events. The child who's been invaded by my good friend's self-blame. With a name like secrecy, I do like to stay in the shadows, but you seem keen. And in the interest of putting the record straight, here I am. And to tell you the truth, I can't even imagine where the child would be without me. In a bad place, that's for sure. Oh, I know my reputation. I know what you probably think of me, but let me tell you, everything you think you know about me is completely wrong. You see, I protect the child. Most of the time, I'm the only protection the child has. In fact, it's probably closer to all the time. You like to believe that if the child tells their story or trusts in an adult around them about what happened to them, that it will help them heal, or whatever it is that you people do. And I know you've done your research into your so-called devastating effects of familial and institutional child sexual and physical abuse. You might even give yourself credit for better understanding what trauma can do to a child's brain. Good for you. Well, let me tell you, there are lots of ways that I can make sure a child never discloses what happened to them to any so-called safe or trusted adult. That's just unrealistic, even after everything you think you know. And I don't have to work that hard to keep these kids convinced to do that. It gets reinforced all the time. You remember the saying, children should be seen and not heard? You probably think it's a thing of the past, but let me tell you, it is well and truly alive. It's just better hidden these days. I mean, ask yourself, how often are children really invited to share their experience? How often do adults actually go out and seek their stories, or even listen to them? You see how easy this is. And even if they do tell, all it takes is one person to say, "Why didn't you speak up earlier?" Or anything that gets fed into my great ally self-blame, and bam, the kid runs a mile, and everything that I've been telling them gets super duper reinforced. Just like that. It's actually so helpful to me whenever adults second guess themselves, or avoid the can of worms, or don't think through what talking about the trauma will do to the child. Thank you. And the child sees through your good intentions. These kids are so finely tuned by self-blame that all it takes... I find myself in an
Sorry, that just kind of glitched a bit at the end there, but it had finished. So the reason that we talk about secrecy so much, I think, at Emerging Minds is that there's a lot, again, there's a lot that children that have gone through trauma are up against, isn't there? There's a lot of ways which they're discouraged to tell their stories, or that they might have challenges in telling their stories. And so this is why, for an early intervention and prevention strategy, if we are truly to believe that children's safety is everyone's business, that a lot of the work that we've been doing over the last 5 years is working with practitioners like yourself around developing strategies to help children tell their stories at the earliest possible time, and to make sure that when they do tell these stories, that they're always believed, and that practitioners are armed with a confident approach which allows them to help the child move away from secrecy or self-blame. And that's a lot of what we want to talk about tonight with Kate. So there's been no time in history, we think, where children are more affected by failure stories. So the discourse of failure is more prevalent now than it ever has been in the history. And we see this with children and young people, the levels of depression and anxiety that they feel so often around this sense that they're a loser, that their life is futile, that there's no hope, that there are so many people that are better than them. Research has found that between 38 and 49% of children living with intellectual disability are reported to have mental health concerns. This is considerably higher than the rest of the child and adolescent community in Australia. Children with intellectual disability are more likely to be impacted by a belief that their trauma experience was their fault, exacerbating the effects of secrecy. So really what we want to talk about tonight are ways that as practitioners and as adults that we can help children with intellectual disability to move past the grips of secrecy. So my first question for Kate tonight, and welcome again, Kate. Kate, what are some of the considerations for children living with intellectual disability that contributes to secrecy after their traumatic events and experiences?
I think, firstly, I just want to acknowledge that is such a powerful video that Emerging Minds has made around secrecy, and how I think it's really important if we could kind of try to visualize secrecy as a character or a person. It can help to give, I guess, us all as clinicians a bit more insight into the power of secrecy and how important it is to address that. Secrecy and combating secrecy is a core component for all children who've experienced complex trauma, but further magnified for children living with intellectual disability for a whole range of factors, both within the child and family, but also at a societal level. So I think we need to consider, and these are all themes that come from the research, that the developmental and behavioural differences that can be associated with intellectual disability can create complexity in firstly identifying complex trauma in children, but then also knowing how to respond to that and how to support children after those experiences. And certainly the literature talks about that, the impact of that diagnostic overshadowing, which means that we can be adding to a sense of secrecy, because often behavioural changes that a child might show can be inaccurately associated with their disability, whether it, rather than being recognition of the complex trauma that they are currently or have experienced. I think we need to be to consider that a child with an intellectual disability may actually have life experiences prior to the trauma they experience that are different to their peers who don't have an intellectual disability. And this can contribute to their difficulties with identifying and understanding that they've experienced trauma, and knowing to actually speak to somebody about that. So the literature talks about the fact that children with an intellectual disability may have more people completing quite invasive personal activities with them across their lifetime. So understanding those normal interpersonal boundaries can be difficult for children with intellectual disability and contribute to a sense of secrecy when something hasn't felt right for them. Of course, I think we would all experience as clinicians that the cognitive and communication barriers that children might have associated with their intellectual disability can create barriers to them being able to share information about abuse. And we're going to talk about that in a lot more of a practical way tonight. I think we need to acknowledge that there still remains in this day and age a lot of societal myths around abuse in regards to children with intellectual disability. So research has identified that this includes beliefs in practitioners and members of the public that people with intellectual disabilities do not have the same response to trauma as people without intellectual disability, and that people with intellectual disability can't benefit from therapy for trauma, both of which we need to emphasise are myths, not facts and not reality, but they contribute to societal secrecy around these things. You know, I flagged on the slide here that sometimes, you know, in the context of caring for a child with disability, families may be low on capacity in terms of their personal resources of time and energy, and they may not have had education to understand the risks for them of their child experiencing abuse. So it may not be something that they're even looking for, that's even on their radar or they're even considering. So in that way, we're contributing to secrecy for that child around their experiences. And then finally, I just kind of want to flag what might really feel like a bit of an uncomfortable space for us all to sit in. But we need to recognise that we all bring professional biases to our work. And research has actually shown that there is a very high feeling amongst mental health professionals that children with intellectual disability should be seen for mental health interventions through specialist services. And unfortunately, what that belief has led to is referral pathways that actually reduce children's opportunity to access helpful supports for their trauma. So unintentionally, we are creating, you know, support services in societies that are contributing to secrecy for children because we're creating barriers to them getting the supports they require.
Thanks, Kate. Some, really insightful points there. I just want to talk a little bit about some of the strategies that might help children and families overcome secrecy or self-blame in their lives. And a big piece of the work that Emerging Minds has done in the last couple of years has been an online course, which is it's called Child-Centred and Communication-Focused Service Provision with Children with Disabilities. And there is, at the end of this slideshow or at the end of our presentation, some resources which you might like to look at from Emerging Minds, including this online course. And what practitioners told us when we were doing this course with them is that there are a number of different ways that they can help children and families with disability to tell their stories. And this is a diagram of some of the intel that we've been provided from practitioners. And that's around a path model, which we call possibilities, alternatives, trying out, and holistic. Possibilities really is thinking when you first meet with a child and their family, and that's along the lines of what Kate was saying, making sure that diagnostic overshadowing is not happening, that the possibilities and the preferences and the values and the attitudes that a child has, even though they might have communication difficulties or challenges, that the practitioner maintains a curiosity about those, that events like trauma or even happy events in their lives have just as much an impact on children with disabilities as any other kid. And how can a practitioner be alert to this, be curious about this? How can a practitioner make sure that they get to know what a kid wants, what a kid values, the relationship that a kid is enjoying, what they might like differently in their relationships? The alternatives in the path model has really been around thinking about what's working and what's not working for a family, and being able to help work with a family, really to become co-researchers in what works in that family, what they've tried in the past, the history of resilience and connection and overcoming challenges that's so often so evident in the rich histories that families of children with intellectual disabilities come to see practitioners with. Trying out is really often making plans with families to try things out, to help children to move beyond self-blame or secrecy, to help children feel less like a failure, to reconnect them with the things that they like about themselves, or to grow or to develop things that they like about themselves. And of course, the holistic part of the path model is really thinking about every aspect of a child's life. And so when you look at trauma, it's every aspect of a child's life that is impacted by secrecy and self-blame so often. And so as practitioners, we can't be having a conversation with children or their families about trauma without a really strong understanding of what they want for every aspect of their life, but also how the trauma has affected those aspects. So as I said, this is a little very brief snapshot of some of the kind of intel that we've gained from practitioners and people with lived experiences at Emerging Minds. And something that we explain in much more detail in our online courses, which I'll talk to you about a little bit later tonight. So Kate, these are some of the strategies that we've heard from practitioners, like yourself, and I'm just wondering, what are some of the strategies that you use for overcoming communication challenges, so that children really living with intellectual disability can share their stories?
And I think the thing about communication is it's a part of everything, isn't it? So, all of our clinical work, regardless of what profession we sit in, is essentially based on communication with the children and families that we come in contact with. So, of course, it's incredibly challenging if we're looking to be able to support a child and family where there's those communication barriers. And it's really, really common in the context of a child having an intellectual disability. I think absolutely the first starting place is we just need to learn about that child's communication from people who know them well. It's absolutely a critical starting point. And probably the best way that I find to do that is just to ask those really powerful information collecting open-ended questions. So I'd be saying things to families like, how do you know that Kate has understood something when you're talking with her? When is Kate best able to explain how she's feeling? What seems to help Kate when she seems stuck with trying to explain something? Those really rich questions will draw out very, very helpful information and be a great starting place in getting to know the child that you're working with. I think if I'm going to be delivering an intervention with a child, I can find it really valuable to speak with that child's teacher. As in the context of intellectual disability, a teacher and educator in the early childhood sector is probably, best positioned to be able to explain how we can support that child to engage with activities, participate in interventions, and the types of modifications that work for that child's learning. Simplifying words that we use, chunking bits of information into smaller amounts, and just generally slowing down the rate that we talk at are really simple strategies, and yet they are highly effective for increasing the success of communication with a child who has an intellectual disability. So, they're little things that we can just all be doing all of the time that don't require specialist skills at all. I think in terms of simplifying information, we know that timeframes can be a particularly difficult concept for children with intellectual disability. And if we were to take the time to reflect on conversations that we often have in mental health treatments, often we are referencing events in the past, and there's lots of conversation around timeframes. So even just thinking about how we can make that information a lot more explicit. So for example, I might not say to a child, oh, we're going to chat about what happened last year. I might actually say to a child, we're going to talk about what happened when you were in year 4 in Mr. Moss's class. So making that information as, explicit as possible, rather than those general kind of timeframe concepts. And then, of course, using as many visual supports as possible is a very known effective strategy for children with intellectual disability. So that can be really simple things. That can be using some gesture as we talk. It can be doodling out or drawing out some simple drawings as we talk. It might be using some photos or some videos, or acting out with some little figurines. There's so many little simple ways that we can meet children's communication support needs that will then enable an intervention to be accessible to them.
Thanks so much, Kate. Within that, you've spoken about some really wonderful strategies, which were fascinating in terms of overcoming communication barriers. But can you talk a little bit about helping children to express themselves with their nonverbal?
And look, first of all, we have to acknowledge this is really confronting as a clinician, particularly if typically your work with people is based on verbal conversations with them. To meet a child whose intellectual disability has then impacted their ability to express themselves verbally can feel like a really hard, confronting space. What I would encourage everyone, though, to recognise is that a lot of children who are what we would class as non-verbal or minimally speaking do not necessarily have that same level of difficulty with their understanding skills. So that's a really good place to come from, again, is finding out about that child as a unique little individual. So what are their communication skills? How do we give them information? How do they express themselves? If that child uses alternative and augmentative communication, so you might see that written as AAC on their referral, And that might include things like a dedicated communication device, or perhaps communication apps on an iPad. You know, perhaps they use writing or spelling or eye gaze or keyword signing for communication. Then you may need to consider thinking about working with a communication partner who's going to work in that interpreter kind of role for you. And that can work really, really well. And that can enable that child to participate in your service. But obviously, we've got to be mindful, because of the content of the discussions, just mindful who that communication partner might be in that circumstance. And then, you know, there are the children with intellectual disability whose communication is based on their body language and their behaviour. And if that's the case, we need to start to create some shared understanding about what that child's body language and behaviour means.
Thank you, Kate. I really appreciate all that you've said there, you know, particularly about talking with non-verbal children who are non-verbal. I just want to change tact a little bit now and talk about helping children with intellectual disability to make power overt. And this is something that can be really, I think, as you've described, Kate, can be quite challenging when children are challenged in their communication. But in working with children who are consumed by stories of self-blame, it's really important to be thinking about ways that we can look for small cracks in the. They might have previous experiences of professionals that haven't been positive. But when we're able to work with them in really innovative and careful ways, we can begin to help them to consider the power differences between adults and children in a way that helps them to challenge self-blame. So this is important knowledge that you held as a practitioner that can help children to take the first step in challenging the unhelpful meanings they've made from their experiences of trauma. To achieve this, obviously, that we as practitioners need to move beyond traditional assessment notions of work, or we need to move beyond, as Kate was saying, understandings of children which, you know, where we understand them completely through their disability. Developing activities that move children from just recipients in our sessions to actual contributors, no matter their communication abilities or not, will really help them to make meaning of power and the important steps in challenging feelings of self-blame. So what I want to do tonight is introduce you to Taj. Now, Taj is a child, obviously you'll see through this, who communicates quite well, and his communication challenges are not acute. However, through showing you this activity that our practitioner works through with Taj, we want to provide you with a little bit of a sense of some of the activities that might actually start to help to make power overt in the meaning making of a child who believes that their experience of trauma was their fault. I'm going to now hand you over to Taj and his practitioner.
Okay, so I'm going to write 2 headings on this piece of paper. On one side, we're going to write 9-year-old boy. You said you were 9 when Uncle Craig did those things to you?
Yeah, maybe after I turned 9, but I was almost 10 when it stopped.
Okay, what if we write 9-year-old boy on this side of the paper, and on the other side we'll... How old do you think your Uncle Craig was?
Dunno. I think he's a couple years older than Mum, and she's 38.
Okay, so should we write 40-year-old man? Would that work?
I guess.
Great. So Taj, how smart is Uncle Craig? You mentioned he used to talk to you about Harry Potter books. Does that mean he's smart, or at least that he reads a lot?
Yeah, he's pretty smart. He uses heaps of big words I don't really get.
Okay, I'll write down pretty smart. And did you tell me your younger brother is 9 now?
Yeah, he's 10 in a couple of weeks.
And it's Jason, right?
Yeah.
Compared to a 40-year-old man, how much does Jason or another 9-year-old child know?
Well, Jason's heaps dumb sometimes. Mum always has to help him with homework, and it's real easy stuff, and he still can't get his B's and D's right.
Okay, we'll put down still learning. I'm thinking a 9-year-old would be in year 4. Is that about right?
Yep.
And what about Uncle Craig? I wonder if he was still learning stuff or if he knew a lot already.
He knew a lot. He used to come and fix Mum's computer all the time. He was pretty good with that stuff.
Okay, should we write that down? Uncle Craig knew a lot?
Definitely.
And how do 9-year-olds make decisions about what's right and what's wrong? How do they work out the difference?
When you're 9, you still do some pretty dumb stuff. Jason is always kicking the ball inside, and he never puts his chip packets away. Mum's always on at him. It's so annoying.
Right. So should we put down still learning about right and wrong and needing help from some responsible adults?
I guess so, yeah.
And what about Uncle Craig and other adults? Do they need reminding?
No. You should just know by then, like after you leave school and stuff.
Okay. You'll have to forgive my maths, Taj, but Uncle Craig might have had about 20 years of knowing right from wrong. Does that sound about right?
Yeah, math sucks.
Sure does.
Nearly all of the counsellors in my team work with children as well, and
Okay, so I'm going to write 2 headings on this piece of paper. On one side, and is Uncle Craig bigger and stronger than a 9-year-old? So we've talked a bit about the difference between what a 9-year-old knows and what Uncle Craig might have known. I wonder, Taj, who was more likely to know that the scary things were about to happen? Do you think it was the 9-year-old or the 40-year-old?
I guess the 40-year-old. But Uncle Craig didn't get scared about what happened. That was just me.
Right. Why do you think Uncle Craig wasn't scared of you, but you were scared of him?
I was just a little kid.
Of course. Silly question, really. Shall I write down that the 9-year-old is likely to get scared of the 40-year-old, but the 40-year-old would never get scared of a child?
Yeah. Grown-ups aren't scared of kids.
What about when one person says one thing happened and the other person says something different? If one person is an adult and one is a child, who do you think gets believed more often?
I don't know. The grown-up, I guess. Jason makes up stories sometimes, but Mum never believes him.
Should we put down not always believed by adults for the 9-year-old and always believed for the 40-year-old?
Okay.
Great. Thanks, Taj. Our list is getting quite long now, isn't it? Shall I read out the differences between a 40-year-old and a 9-year-old boy?
Yeah, if you want.
Okay. So the 40-year-old is pretty smart, but the 9-year-old is still learning. 40-year-olds should know right from wrong, but the 9-year-old still needs some help from responsible adults. 40-year-olds are much stronger and more muscly than 9-year-olds. 40-year-olds know a lot about sex, and they would know what's inappropriate to be doing with a 9-year-old and not make them feel scared or bad or confused. But a 9-year-old would have no way of knowing that. 40-year-olds would never be scared of a 9-year-old, but a 9-year-old could easily get scared of a 40-year-old. 40-year-olds would always be believed when they tell something to another adult, but 9-year-olds aren't always believed. What I'd like to do now is see if our list can help us to better understand whose idea the scary things were. Is that okay? And as we discussed last time, you'll let me know at any point if you want to stop or if you'd like to talk about something else. So we've talked a bit about the different.
So what we're really doing there is showing some ways that practitioners can help children who come to our services believing that what happened was their fault, or it happened because they're a bad kid, or it happened because they're a loser, or that it happened because they wanted it to happen, whether that be physical, sexual, emotional trauma, that we're starting to help children recognise the differences between adults and children, and that trauma is never the fault or never the responsibility of a child. Now, again, obviously there, Taj was able to pick up some of those concepts quite easily. And so with some kids with intellectual disability, that kind of exercise might go for weeks. But really, I suppose the point of us showing that is to help you start to think about ways that this practice can be incorporated into practice with children with intellectual disabilities. So, Kate, I want to ask you around that. How do you work with children and families to help make power overt where trauma has occurred?
So I agree, Dan. I think there's a couple of things there that we need as clinicians to bring the knowledge that we have of what are helpful strategies to the context of working with a child with intellectual disability and go, okay, I know that we need to make power overt here. How do I do this maybe at a slower pace, more explicitly, in a modified way, so that we can still have the benefit of that for a child who is living with intellectual disability? We know, and the research tells us, that children with intellectual disabilities are at a higher risk of feeling less control across the events of their life. They can develop a sense of learnt helplessness. And a starting point for clinicians might be around building a general sense of choice, control and autonomy, or increasing feelings of choice, control and autonomy more broadly in the child's life, to better position them to start to be able to identify feelings of power and concepts of power, rights and responsibilities. We might also, in recognition of the fact that we know that children with intellectual disabilities often miss out on the same level of education that typically developing peers get around sexual development, education around protective behaviours, we may need as a starting point to either deliver that with the child or connect them with a service that can deliver that in a way that's accessible for the child, in order for them to start to understand concepts of safe relationships and to be able to understand when a boundary has been abused. And then I think we can think about, like, if we look at that example with Taj, an activity like that absolutely could be modified by the clinician for a child who has communication impairments once we've learnt about what that child's difficulties and strengths are. So as a clinician, we might think about starting with much more concrete examples. You know, some of the examples with Taj were quite abstract concepts, but we could certainly build to those by starting with very concrete examples of right and wrong, things adults can do that kids can't do. We might also think about adding some visual communication supports to that kind of task and making it more like a categorization activity rather than a written list. You know, sometimes watching another child through an animated video do an activity can be some pre-learning to help the child with intellectual disability understand what the task is about and better prepare them to have a go at doing a similar task themselves. So there's lots of ways that we can play with that. And then through trial, and I no longer in my life say trial and error, I say trial and observation. But through trial and observation, essentially what we're going to do is be guided by that child and co-design intervention modifications that work for them. That child will show us, if we provide them with an opportunity, they will show us if that modification is helpful for them, if they're able to participate and engage in that task, or whether that modification wasn't helpful. And as we build and trial, just like we talked about in the PATH process, build and trial and build that, we are essentially co-designing those intervention modifications with the child.
Thanks, Kate. I really want to talk a little bit now about participation. And I think this goes to the heart of much of what Kate's been talking about tonight. Now, how do we make sure that if secrecy and self-blame is has such a hold on children with intellectual disability, that as practitioners in classrooms, in other community events, that there is opportunities for genuine participation, that children with intellectual disabilities are able to have activities like the one we saw with Taj modified for them so that they can participate. Because we know that children with intellectual disability, as Kate's been saying, are affected just as much by the events that happen in their lives as any other child. And so when we think about participation as an overarching commitment in our services, we know that we need to find ways to help children participate so that the dominant stories, the dominant failure stories in their lives are not reinforced. So we can find a crack in these problem stories. Research with all adult survivors constantly tells us that they wish that someone after their trauma had have asked them, that they wish that they had been able to be supported to tell their story. And what we know now is that for many adults, they tell us that they lived with their stories of trauma for 10, 20, 30, 40 years before telling anyone. We know that this can be even more difficult for children with intellectual disability. So even where children present to us as withdrawn or disinterested or dysregulated in our sessions with them, the high likelihood is that they are hoping that someone will have the patience and the creativity and the innovation and help them participate in ways that help them tell their stories. Kate, I'm going to ask you about that. Are there certain strategies or counselling modalities that are more successful for you in helping children to help make meaning of what's happened to them? How do they help children move away from self-blame or shame, for example?
So I think, a really great starting point for all clinicians and people who come in contact with a child with intellectual disability who we suspect or know has experienced complex trauma is to initially focus on creating that sense of safety. It's one of the core features of trauma-informed care and refers really to both that physical and psychological safety. But sometimes that can feel overwhelming in the context of a child who might be extremely dysregulated, or the focus is on their behaviours of concern. So for children with intellectual disability, I think a starting place for creating that sense of safety is through collecting information and understanding their unique individualised support needs for how they're able to interact and participate, identifying their likes and their strengths and the things they enjoy in life and the things that bring them joy, and then actively constructing opportunities to jointly participate in those activities with them as a way of creating a context in which you can demonstrate genuine positive regard for that child. And that will go a million miles towards creating that sense of psychological safety for that child. In terms of modifying assessments, there's some really great research emerging that shows us that we can make modifications to assessments and that doesn't impact the validity and the outcomes of those assessments. So there's research by Gilmore, Campbell, and I think I pronounced it, Chauchet, in 2021 that demonstrated when they modified a range of psychopathology questionnaires, so self-report questionnaires, and modified those for removing complex wording, reducing ambiguous wording, reducing the working memory demands, children who were living with intellectual disability were more able to use those assessments, and their responses continued to demonstrate good internal consistency and correlation. For some children, we may need to dip more into informal assessment, and that's okay. So we might need to look at modifying and putting a focus more on things like visually modified Likert scales or behavioural observations from people who know the child well. In terms of modifying evidence-based trauma interventions, we are slowly building the research around modifying more broadly mental health interventions for children with intellectual disability, and then even specifically under that umbrella, modifying trauma-focused interventions for children with intellectual disability. So if you have the opportunity to connect with psychology colleagues who might be making modifications for specific populations, we might be able to draw on some of the techniques that they're using. You know, it may not be that the population is slightly different. They might be working with children with autism spectrum disorder who don't have intellectual disability but have communication challenges. But some of their modifications might work really well for your practice if you're working with a child who has an intellectual disability. Brian Talent and his colleagues through the Intercept Centre in Colorado have researched and trialled adaptations of different psychological interventions specifically with children with intellectual disability. And that's included an adaptation of trauma-focused cognitive behaviour therapy. And he's made those resources and clinical guidelines available freely on the internet. So there are resources out there that we can draw on. So regardless of whether you've provided intervention to a child with intellectual disability before, there are resources to help you to be able to do that. And then more locally in Australia, I would flag to the Mental Health Intellectual Disability Kids Hub that's through the Sydney Children's Hospital Network. And they offer a range of webinars and then a recording of those webinars. And some of those are very specifically related to mental health interventions for children with intellectual disability. I think also we need to consider that sometimes children living with intellectual disability might need support from other allied health practitioners to be able to participate in a mental health intervention. So potentially a starting point is there a speech pathologist involved? Is there an occupational therapist involved? How can we help those referral pathways in that really holistic view of the child, but with view to participating in the interventions that they need. And then I guess just to kind of reinforce that, I kind of feel, Dad, like I'm on your, coattails with this messaging, but I think we need to kind of commit to societal change around the fact that it doesn't need to be a specialist service to provide mental health and trauma-focused support to children with intellectual disability. We need to build our capacity as individual service providers and more broadly as society's services, so that we are, as a community, looking to reduce feelings of secrecy and shame for children with intellectual disability and their families, and, really provide kids with the support that they need to live their best life.
Thank you so much, Kate. Those have been wonderful answers tonight. I'm just going to remind people that all of the content which I've discussed tonight from Emerging Minds can be found on www.emergingminds.com.au. I've left some links there which are to our trauma courses as well as our disability courses. And there's an interesting focus there on trauma-informed care. So thank you, everyone. That's been lovely chatting to you and you, Kate, tonight. So I'll now pass over to you, Nicole, with for some questions.
Thanks very much, Dan and Kate. What an excellent presentation that you've shared with all of us today. So just thank you so much for putting forward such excellent content. And I really liked the way that you've incorporated the videos, in particular the video of secrecy, and putting a character to that. I feel like that's a really nice visualization. And I also wanted to acknowledge that in your comments, you've reflected supporting children with intellectual disability that are verbal, but are also non-verbal, because I think that that's often a group that's not readily recognised, or really attention's highlighted towards them. So I just want to acknowledge that you've spoken to that today, which is really wonderful. So I will invite, if any attendees have any questions, to pop them into the Q&A function, and I can ask them on your behalf. I'll ask them anonymously. But I did have a couple of questions that I wanted to put to you, Dan and Kate, in the first instance. So, Kate, when you were talking before about communication and alternative communication methods, you also spoke a little bit about communication partners. And I'm wondering if you could just share a little bit more about what that looks like and who might be involved in that communication partner role and how to identify them.
Sure. So in my work, sometimes I'm working with children who use really specialised communication support. So they might have a very dedicated high-tech device that they use, and sometimes they've got a very small range of communication partners who know how to use that device, how to support them with using that device. And so services may need to draw from communication partners around that child who understand that specialist technology or those particular ways that child communicates. But I'm also really mindful that I think in the context of mental health support and, particularly trauma-focused support, we probably need to do a bit of preparatory work with the communication partner if they're going to be actively, involved in that process. Just like we would with any family member for any child, we might be actually saying, look, some of this might be confronting. What are you expecting might come out of this conversation? How are you going to feel if something comes out of this conversation that you weren't expecting, or it makes you feel really uncomfortable? And I kind of flagged that because I have seen situations where perhaps the most competent communication partner in a child's life might be a sibling. but actually it may not be appropriate to have the sibling as part of the mental health intervention for that child. So I just kind of wanted to put it out there tonight that when we are working with children with very complex communication needs, drawing on a competent communication partner is vital, but it needs to be done with consideration.
Perfect. Thanks, Kate. It sort of needs to be the most appropriate person in order to support the child in the health service that they're accessing as well.
Yeah, exactly. That's right.
Yeah. Fabulous. The next question that I have is around history taking. So the focus of today's session was more on children and childhood. And throughout our project supporting people with an intellectual disability to access health, we've heard a lot about the challenges transitioning to adulthood, and that often information doesn't necessarily go with them in terms of health information or medical information. So do you have any tips on history taking for health professionals when they're working with children who have experienced trauma?
Do you want me to chat, Dan?
Yeah,
Yeah.
go. Yes, please.
So I think more broadly, this is a known problem that people, service users themselves with intellectual disability raise, and certainly their families and carers. And there is, resources that people can use to help with this. So more and more, I'm encouraging families as their child is heading into upper primary teenage years, I'm kind of saying to them, how are you recording really important health information for your child? Because as they get older, you might start to have support workers coming in and helping you with more activities. They will have transitions coming up in their life. And so showing families options for ways to do that. Some families are really digitally orientated and they're really happy to use things like My Health Record. Other people are like, oh, I'm just an old-fashioned, write it down in a book kind of person. There's a lovely resource designed for adults that's come out of Notre Dame University in Western Australia by Dr. Rachel Scoss, where she's kind of collated together a whole range of health resources specifically for people with intellectual disability. And if you look at that online, embedded in that is a range of electronic links for different tools for collecting information. So I certainly work with families around that. Obviously, and Dan, I might throw to you, in terms of mental health interventions and trauma-focused interventions, you're walking a fine line there, aren't you, about people needing to know certain amounts of information, but obviously wanting to protect people's privacy.
Yeah, I think that's all really, they're all really good points, Kate. And I suppose when we look at the, adolescents or, older adolescents transitioning, we know that for all adolescents at this point in time is when they're often starting to make sense of things that have happened throughout their lives, often for the first time, that things that they may not have had the language or the cognitive space to be able to consider. This is a time in their life where they're so often starting to come to terms or starting to kind of think about the impacts often of injustices in their lives, and this can have, often behavioural consequences for these young people. And so the more that we can do as practitioners to be thinking about these histories and helping young people make sense of what's happened to them, and also, again, I think as we've spoken about tonight, to be making sure that they have the opportunity to make meaning of what's happened, of all their past experiences, through a lens of what's just and what's not just, through a lens of overt power and the difference between adult and child power, and also through a lens of kind of helping them figure out the sort of person that they want to be. And if they want to stand for justice and respect and care in their lives, then you know, there's quite a contrast to the ways that they might have been treated in the past. So I think there are all very possible conversations to be having. You know, obviously, as you've spoken about tonight, Kate, you know, where communication challenges exist, these might need a great deal of patience and care and innovation. But I think in this aspect can be really important conversations for us to be mindful of.
Perfect. Thank you so much. I'm also wondering if you've got any further recommendations around diagnostic overshadowing. So that's often where behaviours are attributed to a person's disability rather than acknowledging that there's something behind the behaviours and that they're a form of communication. Just wondering if you've got any further recommendations from a clinician perspective in being able to identify if you may be using diagnostic overshadowing without being conscious of that, and how you can try and prevent that.
Gosh, it's a week-long conference in itself, isn't it? Look, I think it's great to bring it up as a question and acknowledge it, because this is a very real difficulty as a clinician, regardless of, you know, what your background is. And this comes up, you know, constantly if you're working with children with disabilities, whether that be neurodiversities or whether that be a diagnosed intellectual disability. I think the safest space, I feel, and Dan, I'm really happy for you to kind of bring in alternate views, but as a clinician, I think the safest space is just to always have in the forefront of your mind that children in our country do experience abuse and neglect, and that needs to be a consideration for every single child who presents in front of you as a clinician. So parking disability aside, every time I meet a child, I just want somewhere in my mind for me to be considering, could this child have had these experiences? I think also some of the tools that I use, because in the context of disability, it can be extremely difficult to pull apart behavioural change. So, and sometimes when behaviour and body language is the only way a child has to express all of their life experiences, you know, we can never be 100% sure on what that means for that child. But I think what the research is clearly telling us is that we need to start equipping people around that child with skills of observation, skills of documentation, and someone to talk with them about patterns and to notice change. And we can use strategies to help people to try and understand that change, because in the context of often very stretched caregivers, you know, supporting children with very complex needs, it's a bit hard sometimes to think back and to notice when things changed. So sometimes even using strategies like, have you got any video from Easter? Let's have a look at the video together. Was he doing that at Easter? Okay, so we don't think he was doing that at Easter, so it's been since Easter. There are little clinical strategies that can help families try and contextualise those changes in behaviour, and that can be useful for trying to avoid diagnostic overshadowing and trying to understand what might be happening for the child.
Yeah. I think I agree with everything you've said there, Kate. And just, it might be also worth mentioning, just in terms of your point of, thinking of that when we are meeting a child, that, that trauma is a reality. I think the Australian Child Maltreatment Study, which has just been published, the Medical Journal of Australia provides us with some really sobering statistics on the percentage of Australian children who have been physically, sexually, emotionally abused or have experienced domestic violence. For example, there's some statistics there which tell us that 32% of our children have experienced physical abuse, for example, and 28.5% have experienced sexual abuse, whereas almost 40% have experienced exposure to domestic violence. So these are certainly numbers which, do, I think, reinforce, which is something that practitioners have long known, isn't it? That trauma and abuse is so current in the work that we do, no matter what kind of work, whether we're a specialist trauma practitioner or not. That this is kind of these issues are coming through our door so regularly. The other thing I might say is that I think there's a lot said and written and talked about the limitations of our practice with children with disability, but also really strikes me that this kind of concept of diagnostic overshadowing is such a commonly held thought now, and that practitioners, I know that when Emerging Minds were working with practitioners around our online suite of disability content, the number of practitioners that we met who were really grappling with this idea of how do I avoid, as you're asking, Nicole, how do I avoid diagnostic overshadowing? How do I remain curious to the preferences and the individual needs and the hopes that every child comes to visit me with? And, it strikes me that, that's a very, heartening development, and probably, shows that there's a significant kind of growth in developing the way that we're thinking about children with disabilities, which, is shows that, there's certainly been some momentum in that practice.
And I think you hit the nail on the head, Dan, with that word curiosity, because I find that, often clinicians will say to me, I don't know if I'm looking at complex trauma or ASD. And I think we've got to try and avoid a bit of either or mentality as clinicians and take that holistic path and just be open to the possibility that it could be both. It could be neither. It's not always just one or the other. And that just comes from being curious about that child and their context and their life experiences.
Yeah.
Fabulous, thank you. I've got another question. So it's sort of similar to the previous question, but building on it a little bit, targeting GPs, general practitioners more specifically. Do you have any recommendations on how we can get GPs to assist in identifying trauma in children, with children with an intellectual disability, because they're often the first point of call for people when they're accessing healthcare?
Well, Dan, I know Emerging Minds has done a bit of work in this space, so I'm just going to throw straight to you.
Yeah, so Emerging Minds has done quite a bit of work with our ACGP in the past and currently. So together we run a series of webinars and have produced some online courses, which really I think is a representation of GP's knowledge, and we certainly work with some very skilled general practitioners where trauma and the effects of trauma are certainly forefront in their mind. I think with any profession, you get a broad suite of approaches and attitudes where, you know, you have some professionals where trauma is top of mind for them, where they're always kind of asking themselves, you know, how can I get better at identifying and helping children to tell their stories? But there's still a lot of work, and, you know, like, I think that's with any profession that we continue to, you know, Emerging Minds is definitely one of our responsibilities. To we're working with all professions to think about how we can get better at helping children tell their stories, really. And I think you're right, Nicole, that doing that, you know, in GPs, where often, you know, the majority of families and children will access, you know, probably at least once a year, is a very good place to start.
Excellent. And just before, we'll wrap up shortly, but just before we do, I just wanted to ask Kate and Dan if you've got any sort of final comments or recommendations that you wanted to make for people to take away from today's session.
There was one little point that I had intended to mention and I forgot to, so I'll use this opportunity to do that. But that was basically that I think when we're working with children who have complex communication needs associated with intellectual disability or other types of disability, I think it's totally okay to advocate really strongly that that child may need more time and more funding and more resources to be able to access the mental health intervention that they require for their complex trauma experiences or more broadly their mental well-being. So, you know, I just wanted to let people know that, you know, I certainly as a clinician do a lot of work in that space in my documentation to funding bodies to actually explain how this child needs this intervention. We can look to make this intervention accessible for this child, but that might, you know, will need more time because of their communication support needs and thus essentially more funding. And I think that's a way as a society we can be trying to shift away from specialist services to supporting mainstream services to be able to meet the needs of children.
Yeah, and I think there's been so much practice insight provided by Kate tonight, which has been wonderful. And just, I think, you know, my final message would be, we know that as practitioners across Australia that we're constantly all striving to get better in this area of work, you know, to find innovative practices. So Emerging Minds is really interested in connecting with practitioners who are finding innovative ways of working and have tried new approaches and have had some success with those approaches or even some challenges. So I suppose our hope through planning forums like this is that we just want to keep the conversation going, and we'll be very happy if anyone who's watching tonight would like to contact us and kind of provide us with some of their practice wisdom and experience.
Excellent. Thank you so much. So can I just ask that anyone who has attended today to please take the time to complete the participant evaluation survey via the QR code, which Jade will share on the screen shortly, or also via the link in the chat. And I would really like to say a sincere thank you to both Dan and Kate for delivering such an excellent session today, both the content in the presentation, but also your insights in the Q&A has been really valuable. And I think there's been some really key lessons that we can all take away from today's session. So thank you very much to Dan and Kate, and thank you everyone for your attendance today.
Thanks, Nicole.
Thank you.